So this part of our discussion focuses on the role of consolidation and maintenance therapy in multiple myeloma. This is an area of intensive research, and there are a series of new data available which we'll have the opportunity to discuss with the PIs of the main studies, at least for most of the studies. So when we talk about consolidation therapy, we refer to a very active treatment which is given for a limited period of time with the main objective to improve the quality of the response, to improve the patient's response, to enhance the rate of complete remissions, and to enhance the rate of patients without minimal residual disease. And this is different to what we call maintenance therapy, which is a treatment which is aimed to maintain a good treatment response which has been achieved by induction therapy. And maintenance therapy is given for long and in the ongoing trials as long as possible, as long as the patient is in remission and is able to tolerate maintenance therapy. The aim, of course, of both treatments is to reduce the risk of relapse, to extend the progression-free survival with very good quality of life, and finally to improve and prolong overall survival. Now, the treatments which were available at our last uptake are shown on this slide. Of course, you can use a second transplant in patients who have had a previous transplant if the treatment-free interval is long enough. You have VTT, VRD, bortezomib, and lenalidomide for maintenance therapy, and we have for consolidation therapy, and we have thalidomide, lenalidomide, and bortezomib for maintenance treatment. So let's start with consolidation therapy. So with VTT as consolidation therapy is an excellent treatment. So maybe Antonio, are you willing to respond and to explain the benefits and the limitations of the VTT consolidation treatment trials?
Certainly. As a GMEMA group, we and Michele Cavo leads the study. We did an important study comparing thalidomide dexamethasone versus Velcade thalidomide dexamethasone, and the study clearly shows superiority of the free drug combination over the two drug combination, both in terms of response and progression-free survival. What we consider now probably one of the best options for transplant patient is an induction including 3 to 4 courses of free drug combination, in this case bortezomib, thalidomide, and dexamethasone, followed by autologous transplant, followed by a consolidation, again with a free drug approach, including bortezomib, thalidomide, and dexamethasone. This is probably one of the best opportunities to take the full advantage of both the induction, the transplant, and the consolidation. I would also try to stress a concept that is coming from another studies where basically all patients were in VGPR after autologous transplant, and in those selected patients where we usually might say, well, we have a VGPR, so we might stop the treatment, those patients received 3 courses of consolidation with bortezomib, thalidomide, and dexamethasone. And in this selected population, the CR rate moved from 15% to 45%. So in those already in VGPR patients, the addition of the consolidation triplicate the CR rate.
So what is the best way to measure now minimal residual disease in those patients?
Well, certainly we do not have a very easy approach to really measure the minimal residual disease. The molecular approach is probably one of the best approaches, but still not available everywhere, complicated, restricted to research. Immunofixation negative CR is what we have. Actually, this is not a CR because it's still plenty of disease, what we call immunofixation negative CR. The immunophenotypic definition of complete response could be a way to get and to follow the minimal residual disease.
And what is the status, I mean, of evidence now? Is the evidence which is available for VDD consolidation therapy solid enough to recommend this treatment on a broader basis? Or how do we handle that? How shall we handle this?
Well, certainly I think there are some evidence, and from this point of view, personally, I'm in favor of an approach including for younger patient induction with a free drug regimen, autologous transplant, and again a consolidation, again with the same approach, a free drug regimen. I think this is one of the best way to increase as much as possible the response rate in those patients.
There was a question whether everybody should receive, if you consider consolidation therapy, if a patient who is already in complete remission should also be a candidate for consolidation therapy. I think you have a very strong notion here.
Yeah, my idea is certainly because, again, the major comment here is that what we define as a complete response in myeloma is actually a partial response, because all those patients have at least thousands of copy genes still in their bodies. So in myeloma, we do not have the complete response we might see in the lymphoma patients. So from this point of view, all patients should receive the best possible regimen.
I would like to ask the panelists if they share this notion, or is there somebody who has another approach or opinion here? Peter, do you like to comment here?
Yeah, well, I think that first, the number of CRs is still very small in our trials, relatively spoken. So it would not be very wise, in my view, to make exceptions for that small portion. And as Antonio said, there's still a lot of disease in these patients. So, and then from another view, we would always consider to treat patients in an optimal way. So offer them the opportunities that are available rather than excluding them from effective treatment.
Dr. Davis from Royal Marsden, London, do you share this opinion?
So I think within the context of clinical trials, and I think offering patients consolidation is important, but I would say at the moment we maybe still need some more strong evidence to say that it should be for every patient.
Dr. Malmquist? Yeah.
Well, I think that it has been shown both for thalidomide and bortezomib that those patients who gain most from consolidation are those that are not in VGPR, but I wouldn't take that as an answer to the question. I still believe that you could definitely offer that to all patients, apart from those that are cured, but we don't know who those patients are. So.
Okay. Before we move on to bortezomib consolidation therapy, I would like to ask Professor Fanson from the IMF, IFM, I'm sorry, from the IFM, Intergroup Francophone du Myelome, about his notion regarding a second transplant. Is this something which is still an option, and how often do you practice that?
It's no it's no longer an option in the routine practice, at least in the context of IFM. We are using VTD induction, single transplant, and VTD consolidation. Basically, we feel that we have results coming from different trials, and Dr. Palumbo mentioned at least 2 important trials in Italy showing that consolidation in the post-transplant setting is effective. So we investigated in the past the VTD induction. So we are we have implemented consolidation into routine practice for all patients. But okay, on the other hand, we also feel that we need additional phase 3 trials specifically designed to look at consolidation. And so that will be done in the US, that will be done in Europe, and the European Myeloma Network will look at the VRD consolidation versus no consolidation. So we still consider we need additional data. But
so second transplant is not let's say a consolidation therapy which is now further pursued because we have these novel agents and which are more effective.
Yes, I think it's part. The question of a second transplant is part of the U.S. trial looking at consolidation. But my understanding is that in Europe we are no longer using second transplant in the era of novel agent in the post-transplant setting.
But I agree with you. It's still a question, open question. So, like the U.S.-France trial will address the question, like ours. In the EMN. So hopefully by combining the data we will get an answer.
Would you like to comment your trial where you had a single transplant in one part of the study and double transplant in the other part?
Well, in the combined HOVON GMMG trial there were patients from Germany and from the Netherlands. In the Netherlands the treatment strategy is one high-dose melphalan autologous transplant. In Germany it's 2. So not all patients in Germany got their second transplant, but the majority had it. And what we could see is there is a difference. It's not a big difference, but there is a difference between the outcome in the 2 countries in favor of Germany, probably because of the second transplant in the majority of the patients. We cannot be sure because the trial is not designed to find out about that difference, but it's one of the results that we observe.
So it's still a treatment option which is under investigation?
I think it should be further investigated also in the context of the novel agents in this era, and this is what we discussed is going to happen in the 2 big intergroup trials.
So Dr. Mellqvist, you conducted a very interesting study employing bortezomib as consolidation therapy. Would you like to explain it in more detail to us?
Yes, after high-dose therapy, 3 months after high-dose therapy, patients were randomized to either receive consolidation with bortezomib or no consolidation, which is standard in Scandinavia. And so we investigated just with a single drug, and we saw that the progression-free survival was prolonged with about 35% for those patients receiving bortezomib. And as I mentioned earlier, the effect was most pronounced in patients not achieving at least VGPR after high dose. And just a few days ago, I got the first analysis of the quality of life, and we did not see that bortezomib did harm the quality of life. So, and that's an important aspect, I think.
So I think your patients were scheduled to receive 20 infusions or injections of bortezomib. How many of your patients achieved that goal, roughly?
About 90% of the patients. But we did see that when we started the 2 first cycles, then bortezomib was given twice weekly, and we saw that when we moved to the 4 following cycles with bortezomib once weekly, we had significantly less side effects given it once weekly.
Okay. So we discussed these 3 options. Now we come to lenalidomide as consolidation therapy. And again, it's my privilege to ask Professor François about the results of the French study group which employed lenalidomide maintenance.
Yes, we have used lenalidomide consolidation as a single agent without dexamethasone in the post-transplant setting in IFM 2005-02. And what we were able to show is that we showed an increase in the response rate in approximately 15% of patients, something like that. So that was basically an indirect evidence that consolidation was somewhat effective, even so it was not an optimal consolidation. But yes, we delivered 2 cycles, so that the tolerance was quite good, and after this consolidation, patients were randomized to receive lenalidomide maintenance or no maintenance. But this was a kind of positive experience with consolidation.
For future trials, what would be your recommendation if you employ lenalidomide for consolidation therapy?
Or in the ongoing IFM DFCI trial, in the investigating VRD with or without stem cell transplantation, in the post-transplant setting, patients receive VRD consolidation. So it's we moved from lenalidomide as a single agent to the VRD consolidation.
So, trying to sum up, we have now different options for consolidation therapy. All these treatments induced higher response rates, help to increase progression-free survival. With lenalidomide is different because it's not randomized. So it's an excellent starting point for designing and conducting further trials. I think we should leave it at that level at the time being. But it's worthwhile to consider consolidation in patients even outside of trials. Is that something which you agree?
Yes, we are using consolidation in the routine practice. Yes.
Okay. I think we have to move on. We want to discuss the role of maintenance therapy after stem cell transplantation. And Dr. Davis from the Royal Marsden has a very large experience with thalidomide maintenance therapy. Maybe you will allude to this experience after with thalidomide. Yeah.
So there are a number of studies now looking at the role of thalidomide maintenance after autologous transplantation. All of these studies show there's an improvement in progression-free survival. And our particular study showed that this improvement in progression-free survival was the largest improvement was seen in those patients with good cytogenetics, whereas those patients that had poor cytogenetics failed to benefit from the thalidomide maintenance. I think one of the other things to place into the mix is that the median time that patients have been able to stay on the thalidomide, both in our own study and some of the other studies, has been somewhere between 7 and 9 months. And that's because of the development of some of the neuropathy side effects. And so I think if we're thinking about maintenance treatments, we do have to think about the quality of life of patients as well.
Yeah. But you mentioned that in the meta-analysis, thalidomide maintenance therapy not only showed an improvement in progression-free survival, but also in overall survival.
Yes, so there's actually been 2 meta-analyses now, and they definitely show an improvement in the overall survival as well as the progression-free survival.
So I think the art of therapy would be in selecting the appropriate patient, because there are certainly patients who benefit significantly, who tolerate thalidomide maintenance, low dose, probably 50 milligrams, or what is the optimal dose, 50 or 100?
We don't know the optimal dose. I think, as you say, somewhere between 50 and 100. I think once you start getting up to 200 milligrams, then the patient will probably develop symptoms. And I think, as you say, either patients that have good cytogenetics, or if we can identify those patients that are able to tolerate the drug, then there probably is a role for it.
That would be the target group. Unfortunately, we just can, of course, figure out the cytogenetic risk group, but not the individual tolerance of the patient. So, therefore, I think there's good reason to look for other opportunities and options, and lenalidomide maintenance therapy after high-dose therapy has been studied by the IFM group and by the American groups. So Dr. Faso, do you want to comment on that? Yeah.
Yes, we have two trials. One is the CLGB in the US, and the other one is IFM 2005-42. And both trials have investigated lenalidomide maintenance. And as you know, the trials the results were quite consistent. There is a huge PFS benefit in favor of lenalidomide in both trials. At the present times, there is a survival benefit in CLGB, but no survival difference in IFM. And as you know, there is also some kind of small but true safety signal in at least in the IFM trial, but also in a certain extent in the CLGB trial. So the issue is still a little bit confusing, and so many experts agree to say that we need additional follow-up, and that but the PFS results are really very good, in fact.
So some people, some specialists argue you double the progression-free survival from roughly 22 months to 42, 43 months. That is something which is unprecedented in myeloma. Is it strong enough to offer or to recommend lenalidomide maintenance at the time being?
Oh, even so, we achieved good results in the IFM trial. IFM do not recommend routine maintenance with lenalidomide at the present time. So, yes, we still consider that we are waiting for more follow-up. We would like to see some survival benefit, and on the other hand, looking at quality of life, we also saw a little bit more infections in patients who receive lenalidomide for a very long period of time. We got some patients with a second primary malignancy. So this issue is not totally clear for us.
So in case there is a clear signal in terms of overall survival, then I think the notion would be very positive by almost all experts. If there's only progression-free survival, what you would also ask for is excellent quality of life during progression-free survival in order to opt for this option.
I would basically agree with you.
Okay, thank you very much. So there's another trial which has been conducted by Peter Sonneveld and the Hoven Group employing bortezomib as maintenance therapy after bortezomib-based induction treatment, and you presented excellent results with this concept. Would you please allude a little bit more on this trial?
In this trial that we did with the GMMG with Professor Goldsmith from Heidelberg, we wanted to focus on the concept that we would give bortezomib for induction prior to transplantation and then continue with bortezomib after the transplantation to, let's say, maximize the effect of bortezomib, like has been done, for example, in the VISTA trial. So the total number of bortezomib administrations will be 64. And this included 2 years of maintenance with bortezomib standard dose every other week. And there are a number of conclusions from the trial. First, that if patients start bortezomib maintenance, only 6% has to stop the maintenance treatment because of polyneuropathy. So most of them have no additional polyneuropathy. Second conclusion is that there is a clear benefit in response in a way that there is an upgrade of response from, for example, a very good PR to CR in 12 to 13% of the patients. The third conclusion is that there is a benefit in progression-free survival and overall survival compared to the standard arm, and this is especially achieved in patients with high-risk disease, like patients presenting with renal failure and also some subgroups with cytogenetic abnormalities.
So actually we have now very solid data showing that bortezomib maintenance therapy prolongs survival. We have data that thalidomide maintenance therapy after transplant improves survival, but not in all studies, and there are caveats with this treatment. And we have data showing that lenalidomide maintenance therapy improved survival in the KLGB study, but not in the IMF study. So so we have to wait for maturation of these data in order to come to firm conclusions. But I think the field is moving, and it's very rewarding to be part of this exciting research. So moving forward to the elderly patients, to patients who are not eligible for transplant, there are also some maintenance trials which are worth discussing, and trials have been conducted with thalidomide, with lenalidomide, and then VT and VP after VMP or VMP induction therapy. So again, Dr. Davis, would you briefly comment on the results of the your thalidomide study in elderly patients?
So the number of studies looking at thalidomide in older patients is far fewer than those looking at the role of thalidomide maintenance in the after autologous transplantation. The study we conducted in the UK looked at thalidomide maintenance after patients had either received melphalan and prednisolone as induction treatment, or cyclophosphamide, thalidomide and dexamethasone as induction treatment. And patients were either randomized to receive a low dose of thalidomide or just watch and wait. And again, the study showed an improvement in progression-free survival. But again, those patients that seemed to benefit the most were those patients that had the good cytogenetic profile. And unfortunately, again, there was a side effect profile, meaning that many patients had to stop their therapy prior to their progression.
So it's a difficult choice to use thalidomide or not to use it in elderly patients, isn't it?
I think so. So I think although there is an improvement in progression-free survival, maybe in the older patient, we do need to think about the side effects and think about the quality of life.
Yeah. So let's move on to lenalidomide maintenance treatment after conventional induction therapy, and Dr. Palumbo from Torino is running a very exciting and interesting study. Would you please explain us the present status of your study?
Well, I would first of all make a comment on maintenance, especially in the elderly. I think is a major tool to improve progression-free survival. As a general comment, you might consider that novel agent used in induction are usually giving a progression-free survival of around 24, 27 months. With the addition of a maintenance approach, mainly lenalidomide or bortezomib, you can move from 24 to 31, 37 months. So basically the maintenance is improving the remission duration of approximately 10 months. So from this point of view, maintenance is an important tool, especially when you do not use an autologous transplant as consolidation. And lenalidomide has been shown to improve progression-free survival in randomized studies with increase in also a small signal in increase of secondary malignancy, but certainly the benefit coming from the improving in progression-free survival is significantly higher in comparison to the risk of secondary malignancy that is around 1–2% per year. The other issue is certainly bortezomib, and bortezomib has also been used as maintenance, as also in this case the progression-free survival has been improved of around 10 months. And generally speaking, my comment is that especially with conventional treatment, the maintenance approach may have a major role in prolonging remission duration.
Survival is still an open question.
Survival is still certainly an open question. I think it's too early to make assessment on survival right now. It might come in the future. We do not know yet. in my opinion, the endpoint of progression-free survival to some extent should be considered as a surrogate of efficacy, and from this point of view, being a marker to assess the efficacy of a given treatment.
So, in order to sum up, so we have different options also for elderly patients for maintenance therapy. Thalidomide has been shown to increase progression-free survival in at least 2 studies, but there is no improvement in overall survival. And it is probably not a very good treatment in patients with cytogenetic risk factors. Lenalidomide, we have very exciting data showing a significant increase in progression-free survival. We don't have data showing an improvement in overall survival, and there may be a problem with tolerance, which has been alluded to. Safe maintenance treatments are treatments using Velcade with either thalidomide or prednisone after VMP. But again, here we have an improvement in progression-free survival. What we are looking for is, of course, prolongation of overall survival, and I think we have to wait until these studies mature, and then we will be able to evaluate the impact of these maintenance treatments. I think that would be my conclusion, but I would like to ask the panel if there's any comment on this summary, or whether you would change anything in the wording here.
No, I think you did an excellent job in summarizing it. But I would like to add that maybe in this so far incurable disease, control of disease is important. So I would like to support a statement by Dr. Palumbo that probably maintenance, especially in the elderly setting, is of utmost importance, and we should really work on that.
We should work on an improvement, not only progression-free survival, but progression-free survival with good quality of life, and finally, overall survival. With that saying, I would like to thank you all for participating. Thank you.